So I'm going to talk today about asthma and pregnancy, as you just heard. And of course, my computer is going to freeze. No, here we go. So before we kind of get into the talk, basically what I'm going to take you through is a bit of background about why I think this topic is important. Then we'll talk a little bit about normal pregnancy physiology. And then we'll talk about the interplay of pregnancy with asthma, because there's quite a bit. And then finally, we'll talk about how we should be managing asthma in pregnancy, and then a little bit specifically on managing severe asthma in pregnancy. So in terms of the background, the reason I think this topic is important is, first of all, just because of how common asthma in pregnancy is. It's the most frequent comorbid chronic disease in pregnancy. It affects up to 8% of pregnant women. And of pregnant women with asthma, 45% of them end up needing to seek help for uncontrolled asthma during their pregnancy. That's a lot of people. There is also convincing evidence that, first of all, asthma in general, and then specifically uncontrolled asthma, magnifies the risks of maternal, fetal, and neonatal complications. So not only is this common, but it has a significant impact on outcomes. And then another piece to this that I think makes it important is that the main driver, and we'll talk about this in the presentation, but the main driver of asthma becoming uncontrolled in pregnancy is actually decreased adherence. So we know what's driving it. And we also know that mitigating this, so improving adherence, managing people actively, can mitigate these outcomes. So not only is it common and has an impact, there's also something that we can actually do about it. Okay, so a little bit about normal pregnancy physiology. So first of all, oxygen delivery to the fetus is dependent on uterine artery blood flow, and then obviously maternal oxygen content. And this is near maximal at baseline. So the fetus is basically critically dependent on cardiac output from the mother in order to optimize oxygen delivery. The only way to get more oxygen to the fetus is to increase cardiac output. And we know that pregnant women have increased cardiac output. I don't know if people are aware of how much. It's actually quite impressive. It's a 30 to 50% increase in their cardiac output. And this is achieved via multiple mechanisms. And you can see this is all in the red box. So you have decreased systemic vascular resistance. We have increased stroke volume and increased heart rate. And all of these factors together help to significantly increase cardiac output. How does the actual oxygen transfer happen? And this may be something you remember from med school, but basically you have concurrent exchange. So maternal oxygen transfers to the fetus via the difference in oxygen tension and partial pressure of oxygen between the maternal and fetal circulations. And similarly, that's how CO2 diffuses out. And we'll talk about this a little bit more. Optimizing that exchange between maternal and fetal blood is part of this and is actually affected by asthma. Okay, so we talked about the cardiac component. Let's talk a little bit about the pulmonary component of pregnancy physiology. And you see that's kind of the bottom half of that table. So we'll talk more about the pulmonary changes in pregnancy, but these normal pulmonary changes basically result in a compensated respiratory alkalosis. So patients have a lower CO2, pregnant women have a lower CO2, not always a higher PaO2, but a normal to higher PaO2. Certainly a low PaO2 is not normal in pregnancy. So normal to high, and the PaCO2, the carbon dioxide levels are lower, resulting in this respiratory alkalosis. If you think back to this concurrent exchange mechanism from the last slide and diffusion, so oxygen transfer, and there are multiple other mechanisms we won't get into, but oxygen transfers to the fetus. This is helped by a higher PaO2 from the mother, helping to offload oxygen to the fetus, and CO2 waste is eliminated by the fetus. And this is again helped by the lower CO2 tension in maternal blood, helps to pull out CO2 from the fetus. So that's part of why you have this respiratory alkalosis. How does a pregnant body achieve this? Sometimes the respiratory rate goes up, but that's actually a minimal component. The bigger component is actually the reason the minute ventilation is increased is from a tidal volume increase. So how does the body actually do this? How do we get the tidal volume to be higher? There are a few different mechanisms in terms of the physical mechanisms, and I always find this wild. The ribs in a pregnant patient actually flare out. So the subcostal angle changes, enabling the chest diameter to increase by a few centimeters. In addition, the diaphragm, even though we typically think of the diaphragm as being displaced upwards by the enlarging uterus, which it is, it's actually the diaphragmatic excursion increases during pregnancy up to 2 centimeters. There's significantly more excursion of the diaphragm. In addition to this, there's a high, part of pregnancy is hormonal changes. You have higher progesterone levels, and this stimulates respiratory centers in the brain to breathe more deeply, essentially. So all of these kind of pieces together result in this respiratory alkalosis, and they also result in a subjective shortness of breath, which we call physiologic dyspnea of pregnancy. So pregnant women often you'll see that they look short of breath and they feel short of breath, and this is if it's just due to the physiologic dyspnea component, this is a normal response. What's not normal, you'll see here in this box, spirometry airflow is not affected by pregnancy. It does not change. If a patient has new or worsened airflow limitation, this is not explainable by the pregnant state itself. Suspect underlying airway disease. Asthma is, developed or worsened from other factors, and we'll come back to what these other factors are. The other pieces on the slide, they're interesting. I'm not going to go into them in detail, but just letting you know why we're skipping through it. Okay, so a little bit of a detour just for a minute in terms of thinking about dyspnea during pregnancy in general and not specifically being focused on asthma. How do I think about my differential diagnosis for a patient who is pregnant and comes in dyspneic? I kind of split it into my 3 buckets. One of which is kind of the diagnosis of exclusion, is just this physiologic dyspnea of pregnancy. And then my other 2 buckets are, is there some underlying pre-existing disease that is now worsened or presenting itself, like asthma, which is what we're specifically focusing on, versus do I have a new problem specifically pregnancy related, a PE, amniotic fluid embolism, peripartum cardiomyopathy? Is there something new pregnancy related going on? And then just to, again, be clear that dyspnea of pregnancy is an isolated finding. So no other associated things, no wheeze, no cough, no sputum production, no hypoxia for sure, no tachycardia, arrhythmia. Everything else is normal. We can chalk it up to dyspnea of pregnancy. Okay. So that's kind of the background of, why the topic's important, what normally happens in pregnancy. And now I kind of want to focus on the interplay of pregnancy with asthma. So first of all, what's the effect of pregnancy on asthma? I don't know if this is something you've heard about, not heard about, but there's this common wisdom of thirds that's kind of been around for a long time, which basically states that in women with asthma who become pregnant, a third have their asthma get better during pregnancy, a third have their asthma stay the same during pregnancy, and a third have their asthma worsen during pregnancy. There was a meta-analysis, I think it was maybe more than 5 years ago now, that basically was analyzing 14 studies and actually confirmed this wisdom of thirds. So we've continued to state that this is kind of the breakdown, but there are constantly new studies coming out and the numbers are always different. So there was a big study that came out in 2022 that actually found that nobody got better, 60% were the same, and 40% worsened. I think the exact breakdown is less relevant to us. What's more relevant is knowing and being able to counsel our patients that for many people, their asthma control will change and can be expected to possibly change during pregnancy, so that they are aware to expect it and that we're able to mitigate it as it happens and deal with it as it happens, hopefully before it becomes fully uncontrolled. So of the people who do get worse in pregnancy, that worsening does tend to happen in the 2nd and 3rd trimesters. Okay, so how many pregnant people actually have asthma exacerbations? The range I know is big, but it's a very significant minority. So from the data that we have, 20 to 45% of pregnant asthmatics have an asthma exacerbation during pregnancy, and 10% of them have a severe asthma exacerbation. So what's kind of a predictor of having an asthma exacerbation during pregnancy? None of these things are, I think, very surprising. So asthma severity prior to conception, if you had bad asthma before, you're likely to have an exacerbation during. If you're an active smoker, if you have uncontrolled rhinitis, and if you're obese. A lot of overlap between the patients who have worse asthma control, but not specifically an exacerbation, but pregnant women who are younger, Black or Hispanic, multiparous, obese, lower income and education, and poor baseline asthma control. So we have a good sense of who tends to worsen, become uncontrolled, have exacerbations. which should set us up hopefully well to deal with it. Okay, so what about the effect of asthma on pregnancy itself? What's the impact? First of all, and I think this is probably surprising to many, women with asthma are actually more likely to be subfertile and have trouble getting pregnant to begin with. Once you do become pregnant, asthma itself, just having asthma, even well-controlled asthma, is associated with an increase in both maternal and fetal complications. And having uncontrolled asthma magnifies these risks. On the next two slides, I'll show you some numbers, but here's just a breakdown of this isn't even exhaustive, but of many of the adverse outcomes associated with having asthma. So having antepartum and postpartum hemorrhage, ending up with a C-section, developing gestational diabetes or gestational hypertension or preeclampsia, all of those adverse outcomes for a pregnant mother associated with asthma. On the perinatal side, placenta previa, placental abruption, which is obviously very serious, premature rupture of membranes. And then just again, having asthma itself, increased risk of fetal death, fetal hospitalization, and then low birth weight and small for gestational age babies and cleft lip and palate. So looking at some numbers for this, the chart that I have on the side is actually from a Canadian study of more than 100,000 singleton pregnancies in women with asthma. And you can see that all of these outcomes are significantly higher in women who had antepartum asthma attacks than those with asthma who didn't have asthma attacks. So again, many of these are on the left is the maternal outcomes, and on the right are childhood outcomes. And you can see many of these are ones we talked about before. So preeclampsia, pregnancy-induced hypertension, congenital malformations, and you can see that the numbers, the incidence is real. It's around, I think the range is from like 4 to 10% of the things that we're seeing in this category. And there's real, yes, overall, the incidence is low, but there is real increase in patients who end up with antepartum asthma attacks. The right side, I think, is interesting in terms of childhood outcomes. So yes, not surprising, we know there's a genetic component. Mothers who have asthma and more severe asthma are more likely to pass it on to their children. But I do also think it's interesting, we see that childhood pneumonia rates also go up. And go up more in a mother who had an asthma attack during pregnancy. Okay, so this is a little bit more of the same, just showing, this is actually an older study from 2000, but you can see again that a lot of these adverse outcomes significantly increased in pregnant women with asthma, and with severe asthma, even more increased. So again, just more data to show that there is real impact of asthma on pregnancy, and then it's important and worth paying attention to maintaining good asthma control. We can't get rid of the fact that somebody has asthma, but we can address their control. Any questions so far about what we talked about? We can also save to the end. Okay, so next I want to talk a little bit about the mechanisms of worsening asthma in pregnancy, and then we'll kind of go into management. So this is not a slide that we're going to go into in detail. This is the like the T2 inflammatory cascade. Often when we talk about patients with severe asthma, we talk about a phenotype of patients who have high type 2 inflammation. And so, you know, the question obviously arises, does pregnancy cause worsening type 2 inflammation? Is worsening of asthma during pregnancy related to this underlying cascade that may be difficult for us to control, and it's really about adding on additional medications? And the answer is no, it actually has nothing to do with that. There are not huge, but there are a number of conditions that are involved in the worsening of asthma, or the number of mechanisms involved in the worsening of asthma during pregnancy. There, for example, there's the increased prevalence of GERD, of acid reflux, because you have progestin-induced relaxation of the lower esophageal sphincter, and you also, as the belly gets bigger, have increased upward pressure, and so that can increase asthma-like symptoms. There's also the reality that pregnant women have decreased cell-mediated immunity, and so they're more likely to get sick, and infections, whether it's seasonal influenza or other viruses, are certainly a trigger for asthma for many patients. So, you have And in addition, I think there's the issue with there's like microaspiration and increased rhinitis. Pregnant women tend to have higher levels of rhinitis in general. Again, can be triggers for asthma exacerbation. So you do have a number of factors, some of which are modifiable and some of which are not. But the main driving factor in the studies that we have about why asthma worsens in pregnancy is actually very simple, and it's a decreased adherence to medication. So when we look at the numbers, asthma medication pickup rates actually decreased 17 to 30% during the first trimester. Why do people stop picking up their asthma medication? Lack of information, don't know if the medications are safe or not. Often actually getting misinformation from family doctors about whether or not it is safe. Many family doctors are very knowledgeable about this, some are not. Patients want a natural pregnancy. So, basically, people don't know what to do or don't want to take something because they're not sure if it's safe, and so stop picking up their medications. Not surprisingly, given that this is a driving factor, many of the negative outcomes associated with asthma and pregnancy are actually have been proven to be reduced by what we call active asthma management. And I'll talk about what active asthma management is. It's not rocket science and actually is largely non-pharmacologic. So in the kind of big study that looked at management of asthma and pregnancy and this active asthma management to decrease negative outcomes, the key factor was actually patient education. So talking to patients about identifying their asthma triggers and working to avoid their asthma triggers. Obviously, smoking cessation is the most important, but avoiding other triggers as much as possible as well. And then ensuring patients know how to properly use their medications. So a huge number of patients have inhalers, come into the hospital. I'm sure all of you have seen this, come into the hospital with an asthma exacerbation. You say, "Are you taking your inhalers?" They say, "Yeah, absolutely, I'm taking it." And you go, "How are you taking it?" And they show you, and you look at them and go like, "You are getting none of the medication," that you're like puffing it into the air, into your nose, into your ear, like it's going nowhere near your lungs. And we see that all the time. And it's also really hard to use your inhalers sometimes when you are in the middle of an asthma exacerbation, because to actually be able to inhale it properly is difficult. So making sure patients know how to use their prescriber therapy. And if they're on a medication you don't know how to use, many of the medications actually have like you can Google YouTube clips and they'll show how to inhale it. And also a pharmacist is a phenomenal reference for this. You can have patients say, "Oh, when you go pick up your prescription or take your current inhaler into the pharmacy," and they'll show you how to use it. And they really will. And the other thing is encouraging compliance. So making sure you bring up to patients, even if it's not the reason the patient is seeing you. Let's say I don't know, many of you have clinic, or if they're in the hospital for another reason, but they happen to have asthma, making sure you mention, are you taking your asthma inhalers? Asthma medication is safe to take in pregnancy. Please do make sure you take it, and answering questions that patients have about it. And then in terms of other modifiable risk factors, so yes, infections are a trigger. Make sure people are getting their flu vaccines when pregnant. Peak flows, I think is not actually done as much as we talk about patients doing it, but if patients do have peak flow monitors at home, having them measure, and then having an asthma action plan. So I'm going to detour for a second to show you an asthma action plan. I don't know if any of you guys have seen this before. Asthma Canada has a website. It's very easy to find. If you actually just look up Asthma Action Plan Canada, this is the site that you'll come to. And basically the idea is, and if it's not something that is kind of within your purview to fill out with patients, again, just mentioning to people, and this doesn't need to be patients, if it's loved ones, people most people know somebody with asthma, and encouraging people to kind of have these filled out. So it's kind of if you look through it, it's kind of a knowledge system. So first of all, for people to have easily accessible, like who's my physician, how do I reach them, where's the closest hospital, who's my emergency contact, and then having an easy way for people to assess, hey, my asthma is getting out of control. So you can see in the bottom, I don't know if you can see my cursor, but in the bottom left of the screen, it's saying your asthma is not well controlled if you answer yes to any of the following. And it says, are you using your rescue inhaler for 2 or more puffs per week? Are you waking up at night because of your asthma? Are you stopping exercise because of your asthma? Are you missing school and work because of your asthma? If these things are happening, this should be a prompt for the patient to get seen by a provider before things get worse. Another thing that I actually recommend for everybody, but especially in someone who's pregnant, because we know the impact of uncontrolled asthma, can be so severe, as we talked about, making sure that people are using a spacer or getting access to a spacer so they get their medications. So then the actual plan itself, hold on, I'm just going to change the screen. The actual asthma action plan itself, it looks like this. So patients have, the green, the well-controlled, this is, I'm doing well, this is and they fill out, this is the medication I'm supposed to use when my asthma is well-controlled. And then in orange, my asthma is getting worse. So my sleep's starting to be disrupted. I'm starting to get daytime symptoms. I can't exercise normally, and you can see in that, I don't know if you can see that last bullet that's not bolded, I'm starting to get a cold or a flu. If I know that's a trigger for me, I should act now. And again, kind of having them list out, okay, what medications do I take now? For some patients who are always on a maintenance inhaler, this might not change, or it might be a prompt saying, you know what, have you been provided with an emergency course of prednisone to have at home in case things start getting worse? If so, start taking this now. For patients who have mild intermittent asthma, who aren't on maintenance therapy all the time, but know, hey, infections are my trigger, I'm getting an infection now, I should start my maintenance inhaler therapy now. There are people who only take their maintenance therapy when they're starting to be exposed to a trigger, and that's okay. That's kind of on their plan. This is where we want to catch people when they're in this orange, things are starting to get worse. What we don't want is patients getting to the red, getting to that point where, the reliever's not working, they're turning blue, obviously is bad. They're experiencing shortness of breath at rest. They're having difficulty breathing. We don't want people getting there. One, because it's scary, it's difficult to treat for all the regular reasons. And two, because we know outcomes specifically in pregnancy are worse. And then the last two kind of bullets that were part of this active asthma management, one was frequent visits, which is actually monthly in the study for monitoring. This was clearly not a Canadian study. Nobody's able to see their doctor monthly, or it's very rare. But whether check-ins are possible of some capacity, some increased monitoring has been shown to help. And then managing the comorbid condition. So obviously we talked about smoking cessation. Does the patient have bad reflux that needs management? Do they have bad rhinitis that needs management? And yes, some of the management options are more limited in pregnancy, but to the ability that we can manage, this non-pharmacologic management does help to improve outcomes. Questions about any of this? Okay. So what about in terms of the actual pharmacologic treatment? So, and this is the key, which is why I have it in bold, pharmacologic asthma treatment does not differ in pregnant women. The primary goal is prevent acute exacerbations, optimize asthma control. Whatever medications you're using to get there is fine. So first of all, every patient who is pregnant and asthmatic should have access to a rescue inhaler, whether that's a short-acting beta agonist or a formoterol ICS, formoterol being the long-acting beta agonist that's rapid onset of action, so can be used as a rescue inhaler like Symbicort. And this is kind of what I mentioned up front, but while some medications do have more safety data than others, and I'll talk about what has the most safety data, all short-acting beta agonists, inhaled corticosteroids, LABAs, long-acting beta agonists, and montelukast are considered safe. So whatever your patient is on, especially if they're a patient who doesn't have the best health literacy, is hard to kind of get on different medications or change what they're doing, if their system is working for them, any of these medications are safe, keep them on their existing regimen. Don't try to change it. I mentioned kind of up front, there's variety of knowledge on this in the community, and this is a bit of an old study. It's from 2011, and it was actually from Australia, not Canada, but a full 25% of primary care doctors answered that they would stop or decrease inhaled corticosteroids during pregnancy, because corticosteroids are associated with increased risk of cleft lip palate, the congenital malformations. And so 25% said they would stop or decrease it. However, again, very important to mention, the risk of that is extremely low to begin with. The increased risk is there, but minimal. And there are much, much, much greater risks of adverse events from having poorly controlled asthma. And so the kind of set advice is to continue these medications during pregnancy. This we just talked about. So don't change a patient's pre-pregnancy regimen to new ones with more safety data if it will in any way affect adherence. Obviously, the goal is symptom control, and especially important, anything that leads to maternal hypoxia is going to dramatically affect fetal oxygenation. And so it is essential to prevent maternal hypoxia. You definitely do not want the mother getting to the point where she is hypoxic. Okay, if you are going to start a new medication, what has the most data? So in terms of the inhaled corticosteroid bucket, budesonide is the medication with kind of the longest safety data that we've known for the longest time. There is more recent data about fluticasone that is all very reassuring. In terms of the long-acting beta agonists, salmeterol has the most data, and again, for over the longest period of time. But there have been more recent studies looking at others, and specifically at formoterol, and from the retrospective cohort studies that have been done, that's all very reassuring as well. So if you're starting somebody on something new, and they tolerate these are kind of the ones I would pick from, but any of them are fine. This isn't something that I think you're going to be dealing with, but I just kept in here to mention, in terms of biologics, omalizumab is totally fine to continue if somebody's already on it. There is good safety data. Don't start it because there's risk of anaphylaxis. And then there is less data for the other biologics, and the least data, I think, for dupilumab, but there's more and more coming in. Again, probably not decisions you're going to be making. It's going to be the respirologist making those decisions. Systemic steroids. So again, we talked about cleft palate a little bit before, that steroids are associated, but the risk of the increased risk of cleft palate is very small. There's also risk of hypertension, maternal hypertension, and increased maternal blood sugars, obviously. So there are risks, and it is worth, in the interest of full disclosure and being honest with your patients, it is worth mentioning, yes, there are some small risks, but again, as we saw up front, failure to adequately treat an asthma exacerbation, much higher risk to the mother and to the fetus. Any questions about this? Okay, what about severe asthma? Again, largely does not differ from management in the non-pregnant patient. So a few things to think about. You do want continuous O2 measurements, and you want patients' stats to be in the high 90s. You do not want them to be hypoxic. So your goals might be a little bit higher and your monitoring might be a little bit closer than it would be in a non-pregnant patient. Recall that the normal blood gas in a pregnant woman is alkalotic. So if you have a pregnant woman, you obtain a blood gas and the PCO2 is above 35, even if you still are saying like, hey, it's within the normal range, recall that this might not be normal for pregnancy. So have a lower threshold to be concerned about a normal CO2 or slightly elevated CO2. It's going to represent more severe respiratory compromise than in your non-pregnant patient. Consult OB-GYN early, so don't hesitate to get them involved, and fetal monitoring should be considered as well, because of how much especially if in a patient who's hypercarbic or hypoxic. Okay, and then in terms of positioning, obviously as women are further along in their pregnancy, you're trying to avoid supine positioning, so keeping them seated or in left lateral D-cube to maximize blood flow is important. And then in terms of a severe exacerbation, things that are different from kind of regular outpatient asthma, ipratropium is okay to use. There is safety data, but LAMA is the long-acting, not clear safety data. So if you have a patient with very severe asthma who happens to be on tiotropium as an outpatient, first of all, probably they're seeing their respirologist early in pregnancy, or they should be. Okay to keep them on it, but not something you want to be starting. Okay. Prevention of asthma in offspring. Is this even possible? What are our modifiable risk factors? So we know patients with asthma are more likely to have offspring with asthma. There is a genetic component. There are environmental factors at play as well. What's modifiable? So cigarette smoking during pregnancy increases the rate of the baby developing asthma. Poorly controlled asthma during pregnancy. This I find fascinating, but there are actually differences in peripheral DNA methylation in the offspring. So it's not just that well, you have more severe asthma, so your offspring is more likely to have severe asthma. If you had severe asthma, but your asthma was well controlled during pregnancy, a woman with equally severe asthma, who was more poorly controlled during pregnancy, their offspring will have higher rates of asthma. So getting someone well controlled before they're pregnant and maintaining them throughout pregnancy can actually has a significant impact on their baby, on their child developing asthma. And then this is just a fun one, maternal vitamin D insufficiency. So there have been two randomized controlled trials that looked at maternal vitamin D intake, and this was protective against the development of asthma up to age 3. By age 6, the children lost benefit, so they did ultimately develop asthma, but they were protected in those early years. And you could argue that an asthma exacerbation in a 6-year-old is maybe much more manageable for the child and for a young parent than having a baby 1-year-old, 2-year-old, 3-year-old with severe asthma. So something to consider, putting people on vitamin D. And then actually high dose vitamin D supplementation is recommended for mothers who have children at high risk of developing asthma in general. And I think this was actually a bit faster than time, but I think that was kind of the bulk of my presentation. I wanted to leave some time for questions. Anything? I see there's one thing in the chat, but I don't know.
Thanks, Ariella. Yeah, the chat.
How much vitamin D? I don't remember the dose. I can look it up and send it out to the group. I want to say maybe it was like 5,000 international units, but I have to look it up. I don't know. Any other questions? Okay. All right. Well, thank you for having me speak.
Thanks so much, Ariel. That was great. Yeah, very interesting about the vitamin D piece.
I know.
It's too late for my children to benefit from this knowledge.
You know what? Ultimately, the benefit's lost, but I think those young years can be very scary, especially with asthma. And so any protection is something. But
absolutely. Thanks so much. Thanks all for attending.
All right. Thank you, everybody.